Great. Well, thanks for the group's invitation, and I'm here to try to get a nice discussion to occur and just try to see what we can do, because obviously we've all got different backgrounds, all different knowledge, all different expertise, and basically this is a patient who I've been taking care of, who simply has some issues that are difficult for us to manage. And lifestyle comes to mind as a way that we can think alternatively about the other ways of handling such issues. So let me just get a little started here. So this is a man who has confirmed familial hypercholesterolemia. We know that a lot of patients are diagnosed with that, or at least that's what's in their record. But there's specific globally respected criteria, including Simon Broom and the Dutch Lipid Network criteria, which do and do not necessarily have to include genetic testing to diagnose it. And so he clearly has been diagnosed using both of those criteria, which take into account cholesterol levels, the highest cholesterol level, family history, also tendon xanthomata and arcus senilis and periorbital xanthelasmas, which are commonly found in many people who've had this disorder. And so he clearly has had premature coronary artery disease, which, as you know, is a common issue for a lot of these people. And actually, a little story is he was at Syracuse University for I think it was a football or a basketball game, and he thought he was just having some heartburn. He was actually having angina, unstable angina. And he was quite a young guy. And so he was found to have coronary artery disease. And then basically he's had now I think it's 22 coronary artery stents. I'll tell you about his medications soon, but basically he's been taking clearly evidence-based drugs for years. And also he does not smoke. He does not drink alcohol, except on rare occasion. He's not around anybody smoking. He's been doing his best to be physically active and need a sort of a Mediterranean style diet. But basically still he's having some challenges, and I'll describe those for you. So basically, as you probably recall, familial hypercholesterolemia is a genetic disorder, and it's homozygous or heterozygous. It is basically autosomal dominant, but basically it's the most common autosomal dominant disorder. It's present in approximately 1 out of 250 people. It's a bit higher in people who have French-Canadian backgrounds, South African, Christian Lebanese, and Ashkenazi Jewish background, but basically anyone can get it. It results in very high levels of lipoprotein numbers, particularly low density lipoprotein, and predisposes to premature cardiovascular disease events. Unfortunately, it's only diagnosed in about 10% or less of people. Actually, it's better diagnosed in the Netherlands and other countries. I could tell you more about that later if you're interested, but in general, it's not really well diagnosed. When left untreated, it's the most common life-threatening genetic disorder found around the world in all races and ethnic groups. The first symptom may be sudden death or myocardial infarction, depending upon, again, if it's homozygous or heterozygous. And again, the first symptom may be sudden death or myocardial infarction. Most people, it's like, basically 1 out of 1 million who have the homozygous form, fortunately, who start to have problems as childhood. I can remember one young woman at the age of 11 had coronary artery disease, and she clearly had the homozygous form because her LDL was about 1,000. But other people generally more in like the 250 or 300, 400 range of LDLs like this gentleman. And then there are specific genetic metrics that are measured to look for it. There's about 1,600 SNPs, but if you encapsulate them, basically the focus is on ApoB, PCSK9, and then the LDL receptor. And with the LDL receptor one being more common than some of the other ones. And there are some other ones that are being explored, but those are the general ones that are used. Only about 60 to 80% of people who've got the disorder have those genetic issues identified. So that's why the Simon Broom and the Dutch criteria also include other history and physical exam findings. It can be used again, used to standardize and highly pure criteria. As I was mentioning before, there's Dutch and Simon Broom criteria. Simon Broom are basically British. There's also something called MedPed that was established in the United States. By the way, that one is not as highly respected, but the nice thing about it is if you want to just take into account age and highest LDL, you could potentially use the electronic health record to search for people. So the higher the age, the higher the LDL thresholds, but that's something also that some people tend to use, but it's not as highly respected as the other two. And then, as you probably know, I mean, we use the usual medications, including statins, the gold standard for lowering cardiovascular disease risk by lowering cholesterol. But unfortunately, many people still remain very high. Their LDLs are, sorry, somebody asking something?
Jerry?
It's okay, you can, I think that was somebody had their microphone turned on. Go ahead.
Oh, no problem.
Dr. Black, yeah.
And then, okay, and then we use ezetimibe or Zetia, as many people know. Generic also is like most of the statins, colesevelam or Welchol, other bile acids binding resins, bempedoic acid, which basically has not been shown to lower events, but it does lower cholesterol, works with a somewhat different mechanism. And then there's evolocumab and alirocumab, which are the PCSK9 inhibitors. They're FDA approved for people with familial hypercholesterolemia. That's the Praluent and the Repatha injectable sub-Q drugs. And then there's also LDL apheresis, which we have at the University of Rochester. And then it's also globally used in many different countries. It's been around for at least a couple decades. The PCSK9 inhibitor clinical trials have shown that those with very low LDL are at lower risk than those with higher LDL. So one thing we consider is, in the past, there's been a lot of concern about intracerebral hemorrhage. If someone has an LDL of say 20 or 10, however, these studies with PCSK9 inhibitors have had people who've had LDLs of like 0 or 5. They're doing quite well. So that's brought some thought into our spectrum regarding trying to do the best we can with keeping the LDL way below 70. And less than 55 actually been shown to cause some regression of plaque. And then, as you probably already know, the goal generally is less than 100 milligrams per deciliter for those without cardiovascular disease, and less than 70 or 55 with those with the disease, depending upon whether you're paying attention to the 2018 ACC-AHA guidelines or these European guidelines. European guidelines recommend less than 55. And then obviously, doing the best people can with physical activity, avoiding tobacco, etc. So this guy, by the way, he is someone who was in prison for a period of time, had his own business, got caught doing something financially, and went to prison for a period of time. We treated him with LDL apheresis while he was in prison in Rochester. Before that, he was in Boston, and got released, and now is actually studying in the seminary school. He's a really nice guy. He pays close attention to everything we want to do. He's very appreciative of everything we do. But at the age of 42 was when he had his first cabbage. This is when he was at Syracuse, and he had this angina. And then over time, he's also developed some chronic renal dysfunction with a GFR of 30 to 59, has hypertension. As I mentioned, he's got ischemic disease. He's had some cardiomyopathy. His ejection fraction is not less than 35, but it's definitely lower than what we would consider to be optimal. He also has some depression. He's hypothyroid. He has some history of gastric ulcer disease. Those things are generally quite stable. And he's been treated for with LDL apheresis for about 10 years. So let me just explain. So as many of you know, LDL apheresis is a little bit like dialysis, but people don't come in every 3 days a week to be treated. It's a process where blood is filtered with dextrans sulfate. It basically removes the ApoB100 containing lipoproteins like LDL, very low density lipoprotein, intermediate density lipoproteins, and lipoprotein A, and reduces risk for cardiovascular disease. Each treatment lowers LDL about 80%. And he's been coming in for years. In the last year and a half or so, he's been treated every week. Before that was about every 2 weeks. And he has a right upper extremity fistula used for apheresis. And as I mentioned before, he's not a smoker. He's not around anyone smoking, even though he lives in an apartment, but basically there's no one around him that smokes. And then he drinks occasional alcohol and has been doing his best to eat a so-called standard Mediterranean diet, including fish like salmon about 3 times a week. And he does his best to walk as he can, although more recently, this has been much more limited in the sense that he was able to get in about maybe 7,000 to 10,000 steps per day, just kind of walking in the neighborhood. And then lately it's been very, very minimal because he simply has angina much more easily these days. So this is a sort of a list of his different medications. You can see like he's taking levothyroxine, he's taking drugs like fenofibrate, he's taking ezetimibe, he's taking rosuvastatin, the highest dose, most potent statin per milligram. And basically he's also injecting alirocumab or the PCSK9 inhibitor, also taking Vascepa or icosapent ethyl. It's a little bit controversial these days because the studies in which it was used, reduce it was one and evaporate is another, in which mineral oil was used as a so-called placebo. There's some concerns about that, but in any event, he's been taking that as well. And he also takes, low dose aspirin and some isosorbide and other drugs to just sort of control other things. Okay, and then I just want to kind of explain a few other things. So at the bottom, you can see lipoprotein A. As you probably know, it's another cholesterol containing molecule. It's inherited. If it's elevated in our lab, it's greater than or equal to 30 milligrams per deciliter. His was normal. It's another atherogenic, lipoprotein. So fortunately, that's not something that we have to sort of worry about. And as you can see, so like he had LDL cholesterol, like 46, this was basically pre-treatment. We often measure lipoprotein levels like maybe every 3 months, pre-treatment, post-treatment, going all the way from 46, which is not elevated, but down to 6. So obviously lowering his LDL nicely. His non-HDL, as you may know, non-HDL is a bit more predictive of cardiovascular disease risk because it takes into account many different atherogenic lipoproteins where LDL is calculated and this is not. And basically, his levels have come down quite nicely. At times, his triglycerides have been a bit elevated. That's part of the reason why we haven't taken the icosapent ethyl or Vascepa. And then, again, you can kind of just see that his levels have generally been in the past had been generally pretty well controlled. And then this was back in 2013. This was before he started to use the alirocumab or Praluent, the PCSK9 inhibitor, which lowers LDL about 60 to 70%, a bit higher. And so you can see that the previous slide, it come down a fair amount, since that time. His HDL has never been a major problem. We don't really focus on that anymore, but again, it's not something that we've been concerned about. And as you probably know, we don't really use drugs anymore to sort of change HDL specifically because we don't really have great evidence to support that.
So Dr. Black.
Yes.
I'd like to interrupt you for just a minute. Those are really pretty complicated slides. And I just wondered if Dr. Ostfeld had any questions about what you just, or any of the other panelists.
Well, it's an honor to be here with everyone, and really a terrific case, and one where you and your team are really masterfully managing it. It's tough to coordinate these things, and I imagine particularly tough when someone is incarcerated to navigate apheresis. So that's really quite impressive. And as you've well outlined with familial hypercholesterolemia, the genetic mutation, whether you are heterozygotes or homozygous, you are certainly a profoundly increased risk of heart attack, stroke. The heterozygotes a little bit less, of course, due to the very profoundly elevated LDL levels. And I think and you've done a wonderful job at bringing down the LDL with a variety of medical therapies. And so I guess some things that I would keep in mind, which your team is fully all over, is obviously we want to optimize all other risk factors like blood pressure, and do they have sleep apnea and diabetes, things I know that you are all screening for, but due to time, didn't really have a chance to get into here. And then, of course, given the coronary artery disease, possibly putting on an ARB, angiotensin receptor blocker, but that could be limited somewhat by its chronic kidney disease. Would be something to think about. That's just for general atherosclerosis. One thing that this would be kind of this would be out of the box thinking, but this is sort of an out of the box situation. Certainly increased cholesterol can provide residual risk, but so does increased inflammation, as you know, promoting atherosclerosis, as evidenced by post hoc analyses of the AFCAPS, TEXCAPS trial, and CANTOS. And one could say if their CRP was elevated, this would not be guideline-based medicine, but you're sort of really up, 22 stents, you're really at the limit here. And actually, I wonder even if heart transplant at some point, I don't even know if he would be eligible given the genetic mutation, to be honest. Maybe considering colchicine, even if there's elevated CRP, but you'd be limited by renal function. For the LOCODOC study, where there was some potential benefit with atherosclerotic outcomes in patients with increased, with atherosclerosis. So that would be a sort of an out-of-the-box thing to think about. And thinking about down the line, of course, when CRISPR technology, molecular surgery, which is growing now, companies developing it, where you can actually basically slice out a single gene. That may very well be on the, not super imminent, but on the horizon for something like this. So I think you've done a wonderful job outlining this case, a wonderful job managing this case. You're going to want to be sure all the other risk factors are optimized, of course, as your team is doing. And the things we're talking about now in terms of medical therapy, not touching on lifestyle yet, are kind of rounding errors in regard to things you're doing right now. So wonderful.
Well, thank you for that. Dr. Breakey, any comments?
Yeah.
I know this is, yeah.
Appreciate that.
Sure.
Yeah, I think I'll mention the inflammation, as Dr. Ostfeld mentioned, as a real key cofactor. And so waiting and see how his lifestyle may be pro or anti-inflammatory. And I guess one overarching comment with too is, as you say, in this case where genetics clearly play a role in bringing this cholesterol metric way too high, we got to be careful not just to focus on that and treat that and he's all set. We're going to look at the whole picture as a family doc in the renal function, the inflammation, the other components, because we don't want him just getting that down and thinking he's all set and then ending up with prostate cancer from still eating chicken or cheese. So we haven't heard a lot about his lifestyle yet, and I'll come back around to some additional comments once we do.
And
One
Dr.
other
Bhaskar,
brief
go
comment.
ahead.
Sorry.
Yeah, no, go ahead. Dr.
There was
Ostfeld.
actually an interesting article in JAMA Open Network on FH and looking at the role of lifestyle in it. And of course, this highlights, it was just published quite recently in 2022, that incrementally increasing the health of lifestyle, not smoking, not be obese, a healthy diet, exercise, had incrementally beneficial outcomes in people with just this kind of condition. So you're absolutely right. It is all of the above.
Yeah, and one thing secondarily, based on what you both just mentioned, I greatly appreciate these comments, is because he comes in every week and I can see him every week, it's really helpful because he really pays attention and he hears it multiple times. Like, how often are you walking? How far do you walk? You sure you're not around any tobacco? What's your blood pressure at home? His blood pressure is like 115, systolic over 70 at home. So that's also a very nice part of, I'd say, this ability to, see people so frequently. And that may be part of the reason why he's so attentive and greatly appreciative. So I just wanted to also mention briefly, as a lot of you probably know, we do sometimes lipoprotein electrophoresis in some people just to make sure there's not some kind of an outlying sort of lipid disorder like chylomicronemia. And basically, nothing specifically was found to be a concern back just about a year ago. And he just had hypo-alpha lipoproteinemia, which is his HDL is a bit low, but that's not really the big concern. And then other things and it's actually, I recall we did measure his HSCRP at one point. It was not anything of real concern. It wasn't really sort of elevated. But in any event, not a perfect test, like a lot of things. And so his ApoB has also been quite good. As you know, it's a sort of another measure of, atherogenic lipoproteins. It's ALT, AST are fine. We look for secondary causes of dyslipidemia, very high levels of, say, alk phos, et cetera, for cholestatic liver disease. He doesn't have any of that. He doesn't have nephrotic syndrome, also something we have to sort of make note of, as you mentioned, take care of everything, make sure there's nothing else going on. And then, we can see his creatinine fairly recently was somewhat high, and his GFR is not optimal, but his glucose is okay. His hemoglobin A1C has not been a concern. And that also relates to the fact that when he comes in for LDL apheresis treatments, he actually gets some solumedrol because he sort of had an adverse reaction to the dextrans sulfate filters. And that helps. And then the other thing I wanted to mention is that we've actually written a case report regarding him, partly because what happened was he's very, like I say, he's very attentive. He had 2 of the COVID-19 Pfizer vaccine shots. Then he had a booster. And I believe that it was after the second one, not the booster, that his triglycerides went quite a bit higher to over 1,400, where they were much lower before. Hadn't seen anything in the literature about that, so we published a case report with some of my students and et cetera. And so and then it came back down. And that relates also to what I'll be mentioning in a few minutes as another situation that gets a little bit more complicated. Where as part of the reason I think about lifestyle medicine, because a lot of kind of things are complicated, medications, disorders, tests, whatever. But if you can enhance your lifestyle, it's not simple, but if you can, it could also help in many different ways with many different things.
So Dr. Black, I'm going to interrupt you for 1 second here.
Yeah.
Because we didn't get to hear from Dr. Bhaskar. So Dr. Bhaskar has had a lot of experience as a hospitalist. Do you ever encounter a patient like this?
Oh my goodness. Yeah, thank you. Thank you for having me on. And I mean, it's a fantastic case. I did take care of a lot of cardiac patients, as one can imagine. You know, honestly, Ted, my mind is going to painting a picture of this man in front of me. I'm already like in lifestyle medicine mode. I mean, I can't say anything more than what Dr. Ostfeld, I mean, these guys are, you know, the big cardiologists, but really starting to paint a picture of how much control does he have over his life and choices in life. I didn't get a sense of whether he was still incarcerated or not, but I'm kind of thinking like, ooh, prison food.
He's been out of prison for some years.
Okay.
And he's in seminary. He simply doesn't have a job, but he's basically living in his own apartment.
Okay, thank you. So, but yeah, in terms of the case so far, it is fascinating about how the vaccine seems to be causing some of these adverse events that we're not familiar with. I recently heard a case of somebody who had pretty elevated LFTs after they had their booster for like really no reason, like into the thousands. And then it kind of, you know, came back down again. So my mind is going to, what is that connection between like elevated LFTs, elevated triglycerides, although in his case, it doesn't sound like he had that. So yeah, I don't have much more to add there.
Okay, thank you.
Okay, appreciate it. So basically, this is just a brief description of this abstract that we published over last year, basically describing again that we hadn't seen this before. I couldn't find anything in the literature about triglycerides going up. Some people argue that you got to have triglycerides much greater than 1,300 to have risk for pancreatitis, but there's lots of literature out there that supports it, that it is. And then it came back down. And then he got his booster. He clearly pays close attention to doing the right thing. He has to wear a mask. He comes in, he gets tested every month for COVID as required, because he comes into the cath lab to be treated for LDL apheresis. It stays there like 3 or 4 hours each time. And then here's some results from his coronary angiography last year. He had basically a percutaneous stent placed at that time. And like I said, he's had 22 stents. And no matter what we're doing from medications and lifestyle so far, he still has had some disease that could be pretty problematic. And then here's his echo I was kind of alluding to before. He has some concentric left ventricular hypertrophy. He's got some wall motion abnormalities because of ischemia and some MIs. And he has a little bit of aortic valve sclerosis, but no stenosis, nothing else dramatic. But he sees Chris Cove. I don't know if anybody here knows Chris Cove, is a cardiologist colleague who also manages the situation with me. Okay, and then the next chapter, as I was kind of alluding to, is that he had, and this just goes back a short time, but basically whenever these tests have been available for the COVID-19 PCR, he's had them done. There's many more than these, and they were all negative, and then positive in February. He doesn't know how he got it. He at least doesn't tell us how we may have gotten it, but he was tested positive. Then he could not tolerate treatments. He's been treated with LDL apheresis, the same system made by a company called Canica for years. He was treated in Pittsburgh before he came to see me around 2012 to 13. And now he can't. We've tried at least 3 times to treat him. He can't tolerate them because he has anaphylactic type reactions after being treated for many, many years. The only thing that we can tell has really changed is he had COVID-19. He had a 2-week isolation and came back. And then he was seen by one of our rheumatologists, immunologists, allergy specialist, Teresa Bingaman. And she's considered other options. So we modified the way that we pre-treated him. And we basically gave him some prednisone, solumedrol, Benadryl, albumin. Actually, you can't use albumin. We used a plasma to flush the filters, and cetirizine, basically antihistamine drug. And so far, after about 2 months, we still cannot treat this guy. And his LDL's gone up from like 10 to now over 100, putting him at higher risk. And the current tentative plan is to treat him with this drug, which blocks bradykinin. I've never used before, but we looked it up with Dr. Bingaman, and it has been used in a young woman who has LDL apheresis also, and didn't tolerate it until she got this drug. Because again, we're thinking about a potentially different mechanism in which this drug works that may be of some benefit. So we're going to see if we can try to treat him again next, or actually this Thursday, if possible. So those are the end of my slides. I don't have to keep going. I figured I'd just tell you the story and get your input.
Wow, that's kind of an amazing case. It's way over my head as a simple country radiologist. I'm not even sure where to start. So I'm going to turn this back over to Dr. Ostfeld.
Well, this is, just wonderful, and what a challenging situation. I've never personally encountered that issue. And it makes me think about, we'll put in the we'll obviously dive into the lifestyle issues, but I don't think, obviously this is going to be an all of the above medications and lifestyles for this person. And possibly evenicumab, the injectable ANGPTL3 inhibitor, the lipoprotein lipase, in blocking the inhibitor of lipoprotein lipase, has of course been used in familial hypercholesterolemia. There is that New England Journal article in, forget the year, but by Dr. Rall, may be an option. I haven't personally used that drug, but that may be something that is an option for him. And that can meaningfully lower non-HDL cholesterol in people with FH.
So what was the name of the drug that you were referring to?
Evenicumab.
Oh, yeah.
I'm probably like totally massacring the pronunciation of it. Evenicumab. I think it was like the Ellipse studies was what the study was in the New England Journal of Medicine by Rall. But anyways, it's another injectable. It's not something that I've personally used, so I don't even really know the status of it, but I'm assuming that it might be able to be obtained on compassionate use with a compassionate use request.
Yeah,
So,
there's also inclisiran too, which is FDA approved, but it's basically it doesn't have to be injected as much as the other PCSK9 inhibitors.
Yeah, that's another great idea. I think that would be a very worthwhile thing to try, particularly in the context of no longer currently being able to use apheresis. So it just sounds like a couple of injectable options, and maybe this modification of the bradykinin inhibitor will make him an apheresis candidate. But of course, I think at that point we've kind of reached the limit of medical therapy. Really, I don't know of anything else that would be other than pretty much a rounding error.
Right.
But of course, this is a lifestyle medicine group, and you all are doing a wonderful job with him with that. And as you say, you can see him a lot. So of course, from our perspective, we're going to want him to embrace as much of a minimally processed plant-based diet as possible. We know, of course, that ramping up incremental steps with healthy lifestyle, not smoking, not being obese, healthier diet, exercise, is also incrementally beneficial for obviously people in general, but also people with FH. Just in that JAMA Open Network article from just came out 2022. So there would be that element, and of course this would be something I'd want to push the limits of. 22 stents. I try to have him go down somewhat of an Esselstyn path, to be honest, with 5 or 6 servings of green leafy vegetables a day, lots of fruits, beans, lentils, getting rid of the junk food. He sounds like he's doing pretty well with the dietary pattern. If he's truly eating a Mediterranean style diet, that is a quite healthful dietary pattern. Clearly, we would want them to be healthier, but that's supported by the American College of Cardiology guidelines, and it is predominantly plant-based. And compared to the general population, it's exponentially more healthful than the average American is eating. So that's quite good. But I would certainly want them to pursue more vegetables, more fruits, ramp up the exercise as much as tolerated for him, screen him for sleep apnea if there's anything going for that at all. And there's even in the bucket of rounding errors, you could even talk about oral health. There is some degree of a link between periodontal disease and atherosclerotic risk, and there's that randomized control trial in like 2006-ish in New England Journal of Medicine where they treated people with periodontal disease for 6 months, and those who were treated aggressively versus not had improvement in endothelial function. And that's it. It was just a surrogate endpoint, but like you're kind of at kitchen sink level. So what's the big deal? It's good for your teeth anyway. So why not try it? So I would dive in with, push the limits of the medications that you all are doing a wonderful job of, and then push the lifestyle change as well. And then of course there are aspects of it that I'm not an expert in, psychosocial stress, sleep, but of course we talked about sleep apnea, and those would be things to think about as well. But really a masterful job handling this very, very challenging situation.
Yeah, thank you for
And by
that.
the way, the Mediterranean style diet that he's eating is generally the one that was used in the Predimed study. I know there's been some controversy. It was retracted, but then it was republished after they took into account what family members may be eating, and they didn't keep track of it fully. So that's the general approach he's taking, as far as I can tell. I mean, I'm not there in his house, so I don't know.
Of course, yeah. I mean, there's only so far we can go. And two things along those lines. Yeah, when they redid the analysis, it came out with basically the same numbers. There is interestingly a post hoc analysis, the Predimed study, where people, they asked if they consumed a pro-vegetarian style dietary pattern, meaning no animal products whatsoever. Now, this is a post hoc analysis, but those in the highest group, I forgot if it's quartile or quintile, of a pro-vegetarian dietary pattern had meaningfully lower hazard ratio of the primary outcome. I think actually of mortality, I believe that was the outcome they used in that post hoc analysis. But the thing about the Predimed study, it's great. They compared it, they said low fat, but it was really a more typical Western style dietary pattern as the comparison group because they had about 30% fat. That's not low fat. And with the primary outcome in the Predimed study was driven by stroke, not by heart attack.
Right, 30%. Yep.
Yeah, it was driven by stroke, which of course is great. Nobody wants to have a stroke. But so I would still, that's a great diet compared to how the typical American eats. But I would, push them to go much more plant-based. And, it's tough to teach it. You can outsource some of the education. I do that a lot in clinic. I'll have people watch maybe Game Changers, sometimes Forks Over Knives, although I found it a little harder for people to find Forks Over Knives these days. So I've been leaning more toward Game Changers to recommend they watch. So yeah, great work.
Interesting. So thank you. I know Dr. Milton Mills is out in the audience. You had your hand up. Did you want to comment? I know you're an intensivist in the Washington DC
I
area.
did. And I'm going to be typically blunt as I usually am. Excuse me. I'm sorry. I'm kind of not dressed like everybody else, but I got off a clinic. Look, this dude is tiptoeing around the graveyard. And so why not be blunt with him and just suggest that he do a 12-week trial of being completely plant-based to see how much of a difference it would make. Because in my book, he has nothing to lose. And to keep pussyfooting around with animal protein and all the other stuff he's eating, to me, makes no sense. You can't do all of the other drugs and stuff that he's been doing, and you're playing with his life. He needs to do everything he can to see what kind of a difference it would make. And if he were my patient, I would tell him, look, man, try 12 weeks completely plant-based. I might even try to get him to go raw to see how much of a difference it would make. Because if in fact it would really get his LDL down, get his numbers down to where they need to be, then he could decide, do I want to keep with this and save my life, or do I want to go back to playing Russian roulette with animal foods? Because I just don't understand, what the attraction is with, you know, salmon, dead flesh, and all of the toxins you find in sea animals. It's just not worth it. 22 stents? Are you kidding me? The dude has metal pipes for blood vessels, and trying to give him a heart transplant is trading one set of problems for another. All of those anti-rejection drugs, that's just, it's going to be a nightmare. So I'm like, he's at a point now where he needs drastic action. And to me, switching to a plant-based diet is a whole lot less drastic than all of the other things he's been doing. And
when you say plant-based, you mean vegan?
I mean, absolutely 100% vegan. And you know what the added benefit is, he would recover renal function. Because studies have shown that people who have renal insufficiency that become completely plant-based actually recover renal function, that their nephrons are actually able to repair themselves. So, and again, what I found with my patients is that if you ask them to become vegan, that's too high a mountain to climb. So I don't tell them to I don't ask them to become vegan. I say, I want you to do this for 12 weeks. And if at the end of 12 weeks, you don't feel any better, your numbers are no better, you go back to doing what you were doing. But if you are better, then you can decide, do I want to stay on this path or go back to what I'm doing? 12 weeks gives them an endpoint. It gives them, most people say, you know what, I can do this for 12 weeks to see if this is something I want to stick with. But within 6 weeks, they're feeling so much better, they don't want to go back. So that's what I would propose to them.
Well, one thing I know is that the sustainability of such a diet is a little bit difficult for some people. Everybody's different, but to give them a 12-week trial of it, I don't have any problem with that. I mean, I think he could probably do that.
Sure. And you know, and Dr. Black, you know, the program that we run, the 15-day whole food plant-based jumpstart, basically is the diet that Dr. Ostfeld and Dr. Mills are talking about, which is the Esselstyn style, very low fat, whole food plant-based diet. It's vegan, but it's a subset of vegan that's, you know, healthy vegan. It's not soda and chips. It's, you know, basically whole foods as grown, and no animal products at all, no oils.
Mm-hmm.
And that's what Dr. Esselstyn and, you know, Dr. Ornish demonstrated quite a while ago. Dr. Bhaskar has her hand up, and she's a panelist, so she doesn't even need to raise her hand, but go ahead. I'd love to hear what you have to say.
I was waiting politely for my turn, but okay. Oh my God, like, honestly, I just want this patient, to be honest with you. I'm like, send this man my way. Although I don't have a New York license, so probably shouldn't ask for that. But, you know, so many thoughts are coming up because just like, he says veggie boy, so I'm going to call him Mr. Dr. Veggie Boy.
Dr. Mills.
Dr. Mills.
Yeah.
This is really no time to be, you know, playing around, right? Like the maximum amount of current medical knowledge that we have is being thrown at this man. And if this person came to me, I would really dig down into what is he eating every single day, right? You start there. We know that food has a big part of this whole, you know, this whole thing. Maybe he needs a dietitian, maybe he needs a health coach, right? Like pull in those people who can really help look at, like, from the moment he wakes up in the morning till he goes to bed at night, you know, exactly what's going in his mouth, how much exercise is he really getting? Is he wearing a pedometer, right? Does he have MyFitnessPal where he's recording what's going in his mouth? Totally no oils, no fish, right? And I do want to say whole food plant-based is not vegan. I really have a problem with that because, as you said, Ted, right? Oreo cookies and potato chips are vegan, but they're not whole food plant-based. So being very clear about what we're asking our patient to do. Lots of fresh fruits and vegetables, tons of greens, maybe not even really nuts and seeds and avocados at this time, even though they're a healthy fat or very minimal amounts of it. And of course, lots of beans and legumes, just like that. And it is hard, you know, it's a hard thing to follow all the time. But again, giving him a chance of 6 weeks to 12 weeks, pretty guaranteed that his symptoms are going to get better on this. He's going to feel better. Let's not forget that it's also been shown to improve mood, right? Like he's depressed. I would be depressed if I had 22 stents in my body and a cabbage at 42, right? He's already on an antidepressant. So that mood elevation that comes with eating a healthy, clean diet, like we're talking about, and stress, like who's addressing the stress in this man? Like we don't know what his chronic cortisol levels are. Like he's probably waking up every day going, gosh, thank God I'm still alive. Like I could have died last night in my sleep, right? So maybe even some therapy in that regard, teaching some meditation. Like you got to hit like all the pillars of lifestyle medicine and sleep. We all know about sleep and that relation as well, right? Like I wear an Oura ring now because I want to be sure I'm getting my 7 to 8 hours of sleep a night. So again, I think there's lots and lots of room to have a really good lifestyle medicine, either physician or a team supporting this man as Dr. Block is doing all the things that he's talking about, like really combining, all of it, right? Like really just giving this man the maximum chance of leading hopefully a longer and healthy life. Sorry, I get super passionate. I'll shut up at this point.
No, that was great. No, thank you, Dr. Bhaskar. Dr. Breakey, do you have any more thoughts?
Yes, thank you. I agree with Dr. Bhaskar and Dr. Mills. This person needs all in. I was talking to Dr. Esselstyn after a lecture, and he said, I kind of implied about how I help coach people on foods. And he said, read chapter 6, Moderation Kills. Study, 183 out of 200 stuck with his all-in diet because they were at that teachable moment. They had the coaching, the support they needed to get this done, and they decreased their medications. They helped them to avoid not only heart disease, but cancer and arthritis. And I just saw Dr. Mcdougall chime in. He found 85% compliance after a year in his all-in program. So this idea that Mediterranean plus drugs is good enough, I don't know, I'm sorry, it's not my lifestyle approach. My goal as a lifestyle medicine doc is to decrease meds, is to see where and how I can, at least people give the opportunity to say, now again, no argument, we need medications in this genetic disorder that to help lower his cholesterol, but how can we look at that long list of medications and see by optimizing lifestyle in all of the 6 pillars, can we start to chip away at those and help him to optimize his overall health? So again, there's a tendency to focus on the number. I had a 14-year-old come in with polyuria and fatigue. His glucose was 485. Obviously, he had type 1 diabetes. I referred him to the endocrinology department at U of M. He came back 2 months later and said, good news, I'm on a pump, my sugar's fine, I can eat whatever I want. And I like, is that what they told you? He said, yep, my sugar is controlled by the pump now, I can get back to eating anything I want. And I'm like, type 1 diabetes and hyperlipidemia are not just a number to be treated, they are a genetic kind of brings you to a lower threshold, or I should say a threshold of disease that means you have to be even more in. So while a Mediterranean diet at maybe 70% whole food plant-based, it still includes oil, fish, some cheese, maybe good enough to help be way better than the standard American diet of 11% whole food plant-based. That doesn't mean that, as Dr. Ostfeld has says, this guy should go further. As Dr. Mills said, give it 3 months of an all-in jumpstart for Mcdougall or Esselstyn program, where you're just eating the optimal diet, and then see where we can optimize overall health, vitality, decrease risk of other chronic diseases, and get him on less amount of medications. That's my 2 cents.
Well, part of the issue here is I appreciate everybody's thoughts is I'm not completely convinced that what you're describing is the optimal diet. Like, for example, I've published data in JACC heart failure showing that people with the highest levels of omega-3s, which you don't get in a vegan diet, or obviously a plant-based is different, like you said, but they have lower risk for heart failure than people who have lower levels. And you can't perfectly adjust for every little confounder when you're doing a cohort data analyses, et cetera. But, and then a low-fat diet, sort of extra virgin olive oil, is not been shown to be problematic. So that's, I know that there's people talk about the Esselstyn diet and other approaches that people have taken, but I'm not completely convinced that that's something that's sustainable and going to be beneficial. So that I'm just being completely frank with you, like the other person being frank with me before, which is great.
Yeah, no, I appreciate that. I don't know, John Mcdougall, want to chime in a little bit because you've had a lot of experience.
If I could just say, what's the harm in trying it? Just pushing back.
That's right.
Mhm.
You'll know by trying.
Right.
I'm
Can I
gonna
respond to that?
Google.
Yep, yeah. Dr. Mills has his hand up.
Yeah. You can't when you say that you're not convinced about the optimal level of omega-3s, you're talking about omega-3s in someone who is eating an animal food-based diet. You've got to look at what the optimal level of omega-3s are in someone who is on a plant-based diet, because people who are eating animal foods have an artificially basically inflamed system, and they need higher levels of things like omega-3s to offset a lot of the inflammation that's coming from the animal protein and other things that they're eating. I would respectfully ask you to better acquaint yourself with the literature on plant-based therapies that have been used to reverse heart disease, reverse diabetes, treat cancer, reverse kidney disease. I'm telling you, you're doing yourself and your patients a disservice if you don't understand exactly how powerful plant-based therapies are for treating disease, because there is no medication that has been shown to be as powerful as a plant-based diet can be for reversing either heart disease or diabetes. And that has been proven time and time again. Time and time again.
So thank you for that, Dr. Mills. Dr.
And-
Ostfeld, you have, oh, am I hearing someone else?
Sorry, John
Okay.
Mcdougall wants to comment, but he's saying, can someone turn his audio on? I don't know if
Dr. McDougall, you can turn your own audio on, I believe.
hit the mute button. I just say, I agree with Dr. Mills. Animal protein is pro-inflammatory. It's highly acidic because of the high sulfur containing amino acids. It stimulates IGF-1. It's got the fish are very acidic.
Are you differentiating fish versus beef?
Fish has more cholesterol per 100 calories than beef. Fish is no fiber, so it doesn't support healthy microbiome. It's rich in environmental contaminants, including mercury, PCBs, many others, especially farm fish. It's very acidic, and acid load to the kidneys is a big challenge. And once they start to fail, additional toxins further inflame the heart.
Well, have you heard of resolvins? Have you heard of the oxylipins called resolvins?
Sorry, no.
They're oxylipins created by EPA and DHA, and they have anti-inflammatory effects 1,000 times greater than EPA and DHA. They actively reduce inflammation.
Yeah, well, again, I know how much we want to debate this component, but inflammation is clearly much higher by all markers, whether it's HS-CRP, CRP or other, in people who eat animal protein, the heme iron, the carnitine and choline that metabolize the trimethylamine oxide. Where if you're trying to give something to decrease inflammation instead of not just making inflammation in the first place, to me, and again, what Dr. Mills is saying, that's sort of trying to treat a symptom rather than preventing it in the first place.
Right. Dr. Ostfeld, could you comment on that, and also whether you think like a fish oil equivalent, such as algae-based EPA DHA would be helpful?
So, I mean, in terms of consuming, I certainly encourage my patients to eat a minimally processed plant-based diet. That's what my ideal is. And obviously I try not to have perfection be the enemy of good. Not everybody is willing to do that. And, you give them the information, they make the decisions that they choose to make. In this particular case, this person is clearly an outlier in terms of predisposing risk So I would push them as hard as I could to try to be as fully plant-based as possible. There is indeed controversy about fish. And of course, the ACC guidelines do support it, having some. There are multiple observational studies that suggest consuming fish is not helpful. For example, in Song, JAMA Internal Medicine 2016, replacing just 3% of your calories from fish protein with 3% of calories from animal-based protein from the Physicians Health Study, Nurses Health Study 1, Nurses Health Study 2 cohort was associated with a 6% lower risk of mortality. There are short randomized controlled trials, not long ones, short ones. Evade CAD out of NYU with 100 subjects just for 8 weeks, which was a plant-based diet versus the American Heart Association diet. And the plant-based diet lowered CRP more than the AMA-IHA diet. That was their primary endpoint. Dr. Barnard's group has done a randomized controlled trial of a Mediterranean-style diet versus a low-fat plant-based, not vegan. None of us like the term vegan in terms of from a health perspective for obvious reasons. There's a difference between sugar cookies and kale, but the Mediterranean style diet versus a low fat plant-based diet, and the low fat plant-based diet, they lowered LDL cholesterol more. I can't remember all the metrics, had a variety of other metrics improved, although the Mediterranean style diet lowered LDL more, or blood pressure more in that particular study than did the plant-based arm. There's, of course, Turner McGreevy's weight loss studies looking at a plant-based diet versus others, omnivore, pescatarian, and they lost more weight in his randomized controlled trials on a vegan diet. And I'm stressing randomized controlled trials because those drive the guidelines. And it is, and those are things that, I mean, maybe I'm speaking out of turn, but that are going to really move the needle with cardiologists. The observational studies are incredibly helpful. They're important. That it's the totality of the evidence from basic science to translational to epidemiologic and randomized trials. But what drives the guidelines are randomized controlled trials. That is why a plant-based diet is not currently a class 1 indication in the guideline, because we lack we lack a PREDIMED in it. And we obviously are very familiar with Dr. Esselstyn's case series of 198 subjects with pretty significant coronary artery disease who had substantial improvements in outcomes when they ate a whole food plant-based diet. And that is wonderful. It is a case series, and that's not going to drive guidelines. But look, this guy with his Mediterranean style diet, which is certainly healthier than a typical Western diet, is still having stents and still having issues. So, I'm in the same camp as the people here. I mean, what he's doing so far, there are problems still happening. So it is perfectly reasonable to push for a plant-based diet, which has, like we talked about in the randomized, the PREDIMED study, the post hoc analysis of it, those who ate a plant-based dietary pattern did better. And there's any number of observational studies to support going more plant-based is better. Just the recent one from Willett, where they looked at 5 versus 2 servings of fruits and vegetables a day in the Nurses Health Study, Physicians Health Study, and Nurses Health Study 2, where they found something like a 13% lower mortality with 5 versus 2. And they did a meta-analysis of other prospective cohort studies with like 1.8 million people in it. And my Siri thinks I'm talking to it. And they had also a 13% reduction in mortality when you looked at 5 versus 2 servings of fruits and vegetables a day. So I think everything is pointing in that direction. The guy's still having trouble. Look, Dr. Block has done a terrific job. This is a really challenging situation. I mean, walking around with an LDL of 4, whatever it was when he's first 400 or, whatever, very high, that is tough. And getting him on the medications, on the apheresis, and optimizing the other risk factors, kudos to him, and kudos for him to getting him over to a Mediterranean style diet, which is way better than a typical person eats. We're all on the same page here that we think we have to push the needle as much as possible. I'd be surprised if we're not all on the same page that this is an all of the above thing, medications and lifestyle in this situation, particularly when it comes to the cholesterol lowering medications. And then, so I think, yeah, I would send him to Dr. Barnett's program where he could, adopt a fully plant-based diet. I'm sure, I mean, there's a lot of plant-based stuff going on in Rochester. Dr. Campbell, many others who could help. And I think Dr. Campbell is just probably a stone's throw away from your hospital.
Yeah, I know him. I know him.
So I mean, it is, I think, very appropriate to try that in a monitored setting like Dr. Campbell or Dr. Barnett or many other lifestyle medicine physicians in your area would do. But let's not jump down Dr. Block's throat. He's done a really good job with this guy, and we're just trying to think about, brainstorm all of us together about ways to make it even better.
Yeah, I appreciate it. I'm just trying to use a critical eye, to basically try to understand your perceptions, what supports your thoughts, also what opposes other thoughts, right? You write a grant, you write a proposal for something, you got to think about everything. Those of us who do research and other things. So I appreciate everybody's thoughts.
The Association of Nutrition and Dietitians and supports, now they call it vegan, unfortunately, but they say a vegan diet can be healthful throughout the life cycle, including pregnancy, well planned. That basically means eating, having B12 as well. So it's a quite healthful dietary pattern, and it is supported by the ACC guidelines as well, along with DASH and Mediterranean.
Well, one thing to keep in mind is the dietary guidelines, I think it was 2015, recommended women who, I'm sorry?
The ACC primary prevention was 2019.
I'm talking about the dietary guidelines from 2015.
Yeah,
one of my colleagues, Tom Brenna, who's a nutrition professor at Cornell, helped to write them, and basically they advocate for women who are pregnant to eat fish.
Yeah,
2 to 3 times a week. And I know a lot of people are shaking their heads. Bad idea, but the data support it enough to
I'm not arguing
the dietary guidelines. The dietary guidelines could be influenced by other people.
I'm not arguing against the guidelines, just what Anne says. Anne says that as well. The Association for Nutrition and Dietetics. I'm sure your colleague is familiar with that as well. So these are all options, and what they are slight rounding errors for the general population. But when we're talking about someone who's had 22 cents, rounding errors may matter a lot.
Right. Yeah.
Dr. McDougall, did you unmute yourself?
Let me just jump.
Can you hear me?
Yep, let me just jump in for 1 minute. I just want to let everyone know, as the moderator, I'm going to use my prerogative to keep this going a little longer than the 1 hour, just because we have such a lively conversation going. And Dr. Block, I really thank you for your patience, and because I feel like you're probably a bit outnumbered here, and you're holding up well. And
it's okay.
Yeah, okay.
No worries.
Yeah,
I'm here to take everybody's thoughts, just like I said before.
Good.
I appreciate it.
Oh yeah, no, this is great. Just a second.
Dr. McDouggle has been waiting to talk, and we have, thank you.
Yeah, I'm about to call on Dr. John Mcdougall. Has been doing this for longer than anybody. So Dr. Mcdougall.
Yeah, I was just going to say, Dr. Block, thank you. You reminded me as to why I got out of standard medicine. The frustration, it has to be tremendous on your end. And to not see people get well. I mean, that's very frustrating. I think all of us can speak to what we do now. I mean, not that you don't need the drugs, but they should be secondary to correcting the problem. Yeah, he has a genetic issue, which you can't correct, but there are a lot of things you can correct. He's on a horrible diet. I'd go there first, and before I went to all the trouble and the frustration of putting him on medications. And again, I think I'm speaking for the group here, is we really like the way we practice medicine. And I'm glad I'm out of the frustration.
Yeah, well, thank you for that, Dr. McDougall. So Dr. Block, we do have a program in Rochester that's actually now, because of the pandemic, is now international, and it's on Zoom. And it's only 15 days. And if we could have your patient come in to our program, we run it every month. And if you don't change anything else, don't change any of his medications, just keep doing what you're doing. And let's see what happens with going on that program. What's very inspirational, this gallery that you're seeing, all the rectangles on the screen, we get people, 35, 40, 50 people on the rectangle on the screen together, and they start supporting each other. And they start to believe that this is really going to work. And it's been kind of remarkable. I mean, really amazing. You know, I know we're looking for the randomized control trials, but the problem with randomized control trials is that drugs always win because it's so much easier to do a placebo, but then it is for a drug than it is for broccoli, because people know when they're getting the plastic broccoli. So I just think it's worth a try, as Dr. Ostfeld was saying, as Dr.
Sure.
Breakey and Dr. Bhaskar were saying.
Absolutely.
I think it's worth a try. Yeah. Dr. Ostfeld, you got your hand up.
I do, thank you. Your comment just reminded me of a couple of great studies by Dr. Jenkins. It's a bit of an extrapolation to a person with familial hypercholesterolemia, but Dr. Jenkins is a physician from Canada who invented the portfolio diet, which is basically a high fiber plant-based diet. And he did a couple of randomized controlled trials, one of them where he compared it to a portfolio diet to a control group and to like Mevacor 20 milligrams, I think was his comparison. And in his study, both the portfolio diet and the statin significantly lowered LDL cholesterol, and it fell about, I can't remember if it's points or percent, I don't have it off the top of my head, but 30 or so percent or points, I think it's percent actually, on the portfolio diet, and slightly more, 32, 33% on the statin arm, but argues, of course, for the potential impact of the portfolio diet. It's not comparing a Mediterranean style diet, but just highlighting how it can really lower LDL cholesterol, and it's in a randomized controlled trial format, which is extremely hard to do. And one of the reasons, of course, we fall back on observational prospective cohort studies a lot.
Yeah, Dr. Ostfeld, could you comment? I know, let's go to late 45, and I think we're going to have to call it at that point. But Dr. Ostfeld, could you please comment on the Mediterranean, the PREDIMED study, and how it kind of got people thinking, that low fat doesn't work because it really was only, the control group really only think was 37%. It wasn't even 30% calories from fat. I think they were only around 37% per calories from fat. Yeah.
I think you're right. I mean, they called it a Mediterranean style diet versus a low fat diet. And there were two Mediterranean arms. There was a Mediterranean arm with extra virgin olive oil, and there was a Mediterranean arm with nuts.
Right.
And then there was the control arm, which they called low fat. And I honestly don't remember exactly the percentage. You probably remember better than I, but it was at least 30%, I think, fat. It wasn't a low fat group, but like it's the headline. People, you remember the headline. The headline was a low fat diet. Whenever they talk about it, they say, well, versus a low fat diet. So I think that's why that's in the lay public, that it's a low fat diet. But so the Mediterranean arm did have significantly improved outcomes compared to basically a standard Western diet. Like, duh, I don't think anybody was all that surprised about that. And it was actually driven largely it was driven solely by stroke, not by heart attack, not by mortality, but by stroke. And that's great. I mean, stroke is a terrible outcome. I have to admit that I don't remember the specifics of the hyper specifics of the diet in either arm beyond, broadly what we've talked about. But that's one of that, and Leo and Hart study are a couple of the big ones that put the Mediterranean style diet on the map. And of course, that is largely minimally processed plant-based with a little bit of white meat and a little bit of fish. And so, if all of the patients in the Bronx where I work were eating that way, that would be wonderful, because we're not within a mile of that. And Dr. Bundy in 2021 did a really interesting analysis where he tried to assess, what percentage of the US has an optimal diet. And he found 0.7% had, by their definition, which I'll explain in a second, an optimal diet, and 75% had a poor diet. Their definition of an optimal diet was 4 or 5 of the following: low salt, not sugar sweetened beverages, 4.5 servings of fruits and vegetables a day or more, 3 servings of whole grain, and 2 servings of fatty fish a week. That was their definition of an optimal diet. And if you had 4 or 5 of those, that was ideal. And so 0.7 ideal, 75% poor, which is 0 or 1. Why does it matter? They estimated that if everyone went ideal in that study, after 1 year, cardiovascular event rates in the US would fall by a little more than 40%. So, I mean, that's a big difference. But yeah, that's the best I got for you on the PreadyMed study.
So just FYI, I was a vegan and I didn't eat a lot of Oreos or anything like that for 5 years. It was not sustainable.
Well, I mean, that's everyone has their own way of looking at it.
Yeah,
and that's,
exactly. Everybody's a little different too. Some people can sustain it. Some people, it's right. It's a heterogeneous population. But I appreciate your thoughts, and I'm happy to suggest to him to eat this sort of other diet that you were alluding to for a good 12 weeks. I see no harm in that. That's for sure. And he actually is okay with making his own food. He doesn't order out all the time.
Great.
So I think it'd be feasible.
That's fantastic. Yeah.
Dr.
Okay. I'm just going to do a couple of housekeeping things, and then I think we're going to have to say goodnight. But just upcoming events, May 10th, Tuesday, Lifestyle is Medicine Lecture Series. Dr. Melissa Sunderman, one of Dr. Breakey's colleagues out in Ann Arbor, Michigan, will be talking about moving mountains and the power of movement in nature and reaching the peak of well-being. I know she's in the Grand Canyon right now. She texted me earlier, having a great time out there. Our next Lifestyle Medicine Grand Rounds is Tuesday, May 17th. The guest panelist will be Dr. Sean Hashmi, who is a nephrologist out in California, and also, I believe he's still the treasurer of the American College of Lifestyle Medicine. And a local physician, Dr. Laura Petrescu, will be discussing a patient with what we believe is fatty liver disease and LFT abnormalities, and who is on numerous supplements and a keto diet. So I look forward to seeing everybody there. I'm going to stop sharing now. And I just want to say thank you, everybody. You're going to be receiving an email in the next few minutes after we hang up. And if you click on the link in there, there will be a survey to please fill out. And after you complete the survey, you'll be receiving your certificate for 1 hour of CME. And if you do that every month with us, you'll get 10 or 12 CMEs in a year for nothing. So we're really excited that we had such a lively conversation. This has been recorded and will be put on a YouTube channel. And do any of our panelists have any final comments before we sign off?
Thank you.
All
Ted,
right.
for organizing
Oh, sure. Dr. Breakey, it was great to have you. Dr. Block.
Thank you, everybody. Thanks a lot.
Oh, yeah.
Thank you.
Thank you, Dr. Block.
Good luck
Dr.
with your
Ostfeld.
patient, Dr. Block.
Sorry?
Good luck with your patient, I said.
Oh, thank you.
Yeah, he can do this.
Yeah, absolutely. We're there for him. And Dr. Friedman, thanks for helping to wrangle the cases. And it's been great to see you. And Dr. Mills, thank you from your perch in the Washington, D.C. area. I know you're an intensivist down there. And Dr. John Mcdougall out in Oregon. It's so great to have seen you all tonight. Thank you and have a wonderful evening. Bye-bye.
Thanks again.